Hello, everybody. My name is Eyal Cohen. I'm a pediatrician at the Hospital for Sick Children in the University of Toronto in Toronto. And on behalf of the co-leads of the C6 seminar series, we're very excited to launch a seminar series, which is going to be focused on the clinical care of children with neurodisability and medical complexity. The C6 seminar series stands for Collaborative Conversations with Families to Advance the Clinical Care of Children with Medical Complexities, and is a 10-part seminar series. We're going to focus on what we know about clinical care and topics related to clinical care for these children, what we don't know about clinical care in these topics, and how to best address these important knowledge gaps. I'd like to acknowledge that this initiative is supported by the Lucille Packard Foundation for Children's Health in partnership with Family Voices. I'm going to turn now in a minute to our co-lead, Dr. Rishi Agrawal, who will speak a bit more about this in a few minutes, and just make a few standard remarks for me. We're really excited for everyone who's joined today. We really look forward to your participation and engagement throughout the series. As you can see on the slides that have been circulating, there are some processes for accreditation for those of you who need CME. You're going to have a link to your evaluation. And if we receive your evaluation by Monday, September 20th, we'll be able to claim CME credits for you for today's seminar, and you'll receive details about this by email. One really important thing in the seminar series is we really want to encourage participation. We have both a chat box and a Q&A box. At the end of every session, we will have a Q&A with the panelists, and please submit questions via that Q&A and fill any comments you want for discussion amongst participants in the webinar chat on Zoom. Once we conclude this presentation, we're going to move on to this panel discussion, and we really want to get as many questions and comments as possible. I'm going to now pass on to my good colleague, Dr. Rishi Agrawal, who is our series co-lead. Dr. Agrawal is a professor of pediatrics at Northwestern University Feinberg School of Medicine. He's a complex care physician at Lurie and La Rabida Children's Hospital in Chicago. I first met Rishi over 15 years ago in a conference room in Kansas City that was hosted by the Children's Hospital Association, where a bunch of people got together to try to figure out ways of improving care for children with medical complexity. And I've been incredibly lucky to have seen how he's been able to grow this community of practice together with clinicians, with patients, with families, with policymakers, and is an incredible steward for the complex care community. So it's a pleasure to have Dr. Agrawal introduced today.
Thank you so much, Eyal, and thank you to all of you for being here today. This is such an important topic and series of topics, and your participation and voice are so important in all of this. So as Eyal mentioned, we met 15 years ago in a conference room to talk about the growing population of children with medical complexity and how were we going to respond and serve the needs of these children, youth, and their families. But it's instructive to think about why this population is growing. And in many cases, this population has grown and survived because of clinical advancements, whether that's technology such as gastrostomy tubes and feeding pumps, or mechanical ventilation that has allowed some children to survive their conditions. Advances in medication management, use of various pharmaceutical products, surgical procedures that have allowed many conditions that previously were not survivable past a few years for children who have them to survive for longer periods of time. Advances in ICU care, whether in the neonatal ICU or in the pediatric ICU, that has allowed many children to survive illnesses that otherwise they would not have been able to in the past. So as a result, we have a population that has many new challenges. Some of them have been around for a while, but many challenges that we don't yet know exactly how do we treat well. And these challenges affect quality of life and healthcare utilization, sometimes unnecessary healthcare utilization, and whether there are problems with irritability. We're going to be talking about that, feeding problems, challenges with behavioral health, challenges with managing all those medications that we now have available, but how do we make sure we don't give too many of them, with polypharmacy, challenges with sleep, challenges with feeding. We have gastrostomy feeding, but we have to make sure that that feeding is safe. And so we have challenges with aspiration, challenges with dysregulation of the autonomic nervous system, and the storms and the dysautonomia that can result, and the significant impact on quality of life. So it's just I'm so pleased that we're going to be able to talk about some of these issues through the course of this series. And I'm really happy for the Packard Foundation. Thank you so much for supporting this. In the world that we have built in the last 10 to 15 years, focused more around children with medical complexity and children and youth with special healthcare needs, much of our focus, rightly so, has been on care coordination and financing mechanisms. And those are just so essential. However, care coordination has a ceiling as to what it can accomplish if we lack evidence for the basic care that we provide. And right now, much of what we do clinically, and those of us who are clinicians will probably be able to relate to this, is frankly, it's based on a combination of oral tradition, what we learned from those who we trained with, trial and error, and frankly, luck. And that is not the hallmark of an effective, well-functioning system that maximizes outcomes and quality of life. And if we want to improve those outcomes and we want to lower utilization, it's not enough just to create financing mechanisms and complex care programs. We need to improve the standards of care that are delivered to our patients. And to do that, we need to build a base of clinical evidence to determine and elevate those standards. So we hope that the seminar series will be a step in that direction that will help all involved in the care of children with medical complexity to learn the state of the art for important clinical problems faced by this population, so that the knowledge that we do have is applied as universally and appropriately as possible, but that we also start the conversations for the knowledge that we need to build a base of clinical evidence for the future. Thank you so much, Catherine and Eyal, for leading this effort and for the study that we are about to hear about, and to all of our family partners who give us the priorities and the sense of grounding in order to make sure that what we do is tethered to the needs of families. And thank you finally again, I'll say it again, to the audience for being here. Your participation is just so essential. Please stay engaged. Please tell your colleagues if we have a topic on a particular subspecialty area in a given month. Please invite your subspecialty colleagues to be a part of this, because we really need to form. We need all hands on deck to solve these issues going forward, and we need to collaborate across boundaries to create advancements. So thank you so much, and Eyal, I will turn it back over to you for the rest of our great seminar today.
Thank you, Rishi, for those wise words. I just want to have one really important last piece of housekeeping I just want to pass on to all the participants today. So when we designed this seminar series, we thought it was really important to create a supportive forum and a safe space to have these critical discussions that ultimately will help to improve clinical care. In order to do this, we have partnered with families for this series. Why do we do this? We did this because their participation is essential to improve clinical care. Families are clinical partners in care 24 hours a day, 7 days a week, and their experience and perspectives matter a lot. However, by virtue of this forum being large, I think we have over 490 people registered today, and diverse and virtual, and the nature of these discussions, which involve lived examples that may resurface a variety of reactions, we understand that these conversations may be difficult. If anyone needs support after attending these sessions, we invite them to reach out. And we're going to put some links in the chat box that are going to be shared with you for clinicians, for family members, and for people who experience medical complexity that will hopefully be supportive for those who need them. With that in mind, I'm really honored and delighted to have our family speakers, Tara and Debbie, here today. Every one of our sessions will be partnered with families, and we'll have families speaking in combination with clinicians. Our two speakers today, Tara Hayes is the mother of 3 children, Andrew, who's 13 and has an undiagnosed neuromuscular condition, which keeps him in a limited physical capacity, Seamus, who's 9, and Grace, who is 6. She's been working with the Rhode Island Parent Information Network for over 10 years. She assists families with children with special healthcare needs to receive family-centered care, access services, and help them advocate at the local, state, and national level to create policy and awareness around needs and accessibility. Tara sits on many committees and work groups providing parent perspectives and advocating for families to help create better outcomes. In 2018, she was awarded the Rhode Island Caregiver of the Year Award for her role as a mother to Andrew and her tireless advocacy for all Rhode Island families. Debbie Harris is our second family speaker, is the director of the board of the ARC US, a family navigation specialist for Family Voices of Minnesota, and a family leader for the Collaborative Improvement and Innovation Network to advance care for children with medical complexity, as well as the Children and Youth with Special Healthcare Needs National Research Network, where she serves as a partner. Debbie is a huge public policy advocate who works with the National Working Advisory Group for Paid Leave, huge important issue, and the National Caregiver Advocacy Collaborative of the National Alliance for Caregiving. I'm going to pass on to Debbie and Tara to say some words.
Well, I guess I'll go first. So I'm really happy to be here. I truly respect and honor your decision to involve family members because I think the lived experience can actually help to inform diagnoses, treatment, and the relationships that we form with all of those on our medical teams to help with outcomes. So I have a son, Joshua, who is medically complex. He was born prematurely and had a grade 4 brain hemorrhage at birth. Subsequently has cerebral palsy and laryngeal malacia. I'm just going to say the works so I don't take a lot of your time, but he's very medically complex. We actually just got back from a recent week in the ICU this week. So anyway, I don't want to take a lot of your time, but I'm happy to be here. And I'm even more happy that Josh is home now.
Hi, everyone. Good to be here. Thank you all for joining us. I am, as you heard, the mom of 3. My oldest, Andrew, was born only 5 weeks early, but we found out in the middle of our pregnancy that he had stopped moving, and so therefore developed a lot of medical complex issues, mainly due to muscular tone. And so we've had our share of ins and outs of the NICU and the PICU and doctors and specialists, and we really appreciate taking a look at this view and lens of not only from the doctor's perspective, but from the family's perspective, because we know that even though these children may not be able to speak for themselves and they may not be able to do certain things for themselves physically, they do still have, a very active mind and a very, intelligent way of knowing what's going on for them and knowing how to communicate to others. And so really having the families involved is important so that you know how to understand and read the child, especially when you're going to be caring for them in the long term.
Thank you, Debbie and Tara. Really critical perspectives. And at the end of the didactic session, we're going to bring everyone back together for a panel discussion. I'm now going to introduce our didactic speaker for today, who is Dr. Catherine Diskin. And her presentation will be on knowledge gaps in children with medical complexity and neuroirritability. Dr. Diskin is a staff physician at the Hospital for Sick Children in Toronto, and she's a C6 co-lead. Her research focuses on exploring research priorities for children with medical complexity who have neurologic disabilities. She's also the educational lead for the complex care program at the Hospital for Sick Children. And you'll notice quickly when you hear her speak, she has a lovely Irish accent. So I'm going to pass on to Dr. Diskin. A reminder for everybody to please submit your questions in the chat your questions in the Q&A or any comments in the chat box for discussion. Thank you.
Thank you, Eyal. I'm sure my accent is probably obvious already. I'm delighted to be here, even more delighted that we've pulled together this seminar series. Like Eyal and Rishi said, it's all about participation. And so please use the chat or the Q&A to offer feedback on what I'm about to talk about. We really want to hear what everybody has to say. So, as you know, I'm Catherine. I don't have any relationships with commercial interest to disclose. We do again want to acknowledge the funding that we've received from the Lucille Packard Foundation to run this seminar series. The project that I'm going to discuss received funding from the Canadian Institute of Health Research, CIHR. None of those who are involved in the study have any conflicts of interest to disclose, and off-label use of medication is listed within the study results. And we're delighted to share, and I think we've shared in the chat, that this paper was recently accepted for publication in Developmental Medicine and Child Neurology. It's available via open access, and I think Alyssa's sharing it within the chat, and please have a, we think it's worth a read, but hopefully it will inform future research for this group of children. And so for the next few minutes, I'm going to talk about research priorities for children with neurological impairment and medical complexity in high-income countries. And I want to acknowledge the many co-investigators that supported myself and Eyal as we embarked in this study about 2 years ago. And starting with definitions of the population of interest. So children with medical complexity, we know, are children who have substantial family identified service needs with chronic conditions associated with functional limitations and high healthcare use. For the purposes of this study, we used a definition of neurological impairment provided by Jay Barry, that it's any neurological condition primarily arising from the central and/or peripheral nervous system that lasts for at least 12 months unless death intervenes, resulting in systemic or multi-system physiological impairment that requires specialty care. And so kind of touching on what Rishi said at the very beginning, we know that children with medical complexity and those with neurological impairment represent a small subgroup of all children. Where I live in Ontario, they represent less than 1% of the whole pediatric population, but they do use substantial amounts of healthcare, about 25% of pediatric bed days, and about 1/3 of the healthcare spend in pediatrics. Clinically, their presentation varies. It's oftentimes multisystemic in nature, reflecting their underlying illnesses, and that adds another intricacy to the clinical care. And then when we come to the clinical care that we all provide, much of the research to date, particularly in the past decade, has focused on service delivery and care coordination. And while that's incredibly important, there is a significant gap in our clinical knowledge. If we take pneumonia, for example, a lot of the clinical guidelines don't include children with medical complexity or those with neurological impairment, and that reflects the absence of research focused on this particular population. And that represents a real gap in our clinical knowledge and in our clinical practice. And so that prompted us to come up with the objective for this study, which was to develop a list of the top priorities for clinical research in this important group of children, reflecting the consensus of an international expert panel. When we talk about priorities, we were talking about both clinical topics, but also specific research questions. And following on from the development of this objective, it's just important to note that we excluded questions that were going to be related to health service design or delivery, health policy, or those that were related to a specific underlying condition. And so this is how we went about it. We used a modified Delphi methodology, a prioritization methodology using 3 web-based surveys. After we received ethics approval from the Sick Kids Institutional Review Board, the steering committee, which consisted of those listed at the outset of this presentation, were 9 international leaders in complex care from 5 different academic institutions, in addition to a parent representative who received coaching and support from our family center here at Sick Kids. And so after we established our steering committee and got moving, we began to recruit our expert panel. And so the steering group members nominated clinicians that were reflective of a diverse specialties, but also geographic location. It was limited to physicians and nurse practitioners. And that's because the focus of the study was on the their everyday experience as clinicians. We did include caregivers, and they were recruited via social media feeds of the steering group. Round 1 was an elicitation survey. That involved asking an open-ended question of all participants, family caregivers, and clinicians. What were the clinical topics and what were the research questions that needed to be addressed to inform better clinical care for this population? After each survey round, the steering committee reviewed the results and proceeded into the next round. Round 2 had 2 parts. Round 2A focused on clinical topics. So what were the clinical topics that needed additional research? And that part involved both families and clinicians. Round 2B was focused on specific clinical research questions, and that involved only clinicians, not family caregivers. Again, there was a steering committee review, and it proceeded to round 3. Round 3 involved focusing on the specific clinical research questions. And I'll speak about that in a second when we get to results. And then again, there's a steering committee review, and it's those results that were published and those that we're going to discuss today. So just coming back to the first part of our results, we invited 88 clinicians to participate, and 49 did, and we're very grateful to them. As you can see, 28 came from the United States, and the rest came from 8 other countries. 60% were female. 42% were physicians. The remainder were nurse practitioners and a researcher, with over 13 specialties represented. There was also a very great variety in terms of where people clinically practiced, with the most common being a combination of the provision of inpatient, acute, and outpatient care. 76% of study participants described that over 25% of their working week involved the care of children with medical complexity and neurological impairment. We had 12 family caregivers participate. 9 were from Canada and 3 were from Ireland. And they described their children as having a variety of underlying diagnoses. The most common neurological disorders were described most commonly, along with genetic disorders. We also asked about technology use. And so when you look at this slide, as you look at the screen on the left-hand side are the various steps that were involved in the study, and on the right-hand side is the output. And so in round 1, the elicitation survey that involved an open-ended question, 49 clinicians participated, and we received 601 unique responses that reflected 73 clinical topics. The steering committee review of that response involved merging similar overlapping topics. So for example, spasticity and dystonia were merged together as a single topic, disorders of tone. We excluded topics that were not relevant to this particular study, for example, relating to service delivery. And we included topics that were not previously identified, infection control. And we incorporated previously identified research questions. In the United Kingdom, following a James Lind Alliance methodology, a group has published a study looking at prioritization of research topics for children with neurodisability. And from that study, we identified a question relevant to ours. The end result of round 1 was that there were 26 clinical topics and 126 research questions that moved forward to round 2. In round 2, as you may remember, it consisted of 2 parts. 2A involved both clinicians and caregivers, and we asked them to prioritize using a Likert scale the clinical topics. Round 2B involved asking clinicians only to prioritize the top 7 clinical areas and to rate the related research questions. Round 3 then involved the rating of the research questions from round 2, and again only involved clinicians. And so this is the results of round 2, which involved both clinicians and clinical experts. On the left-hand side of your screen, you can see what the clinical topics that were prioritized by clinicians. You can see that regardless of how we calculated their importance, the same 9 appeared as being most important. Caregiver prioritization, you can see on the right-hand side of your screen, there is some overlap with clinicians, but there's also some differences. We also want to highlight that Behavior is mentioned as being the most important clinical topic by caregivers, and it's rated highly also by clinicians. However, that was only introduced by family caregivers. It was not mentioned by clinicians, highlighting the fact that something that wasn't included or recognized by clinicians actually was identified by parents or families, and then subsequently both groups highlighted it as being important. This figure, also taken from the paper, shows the frequency score calculated by the frequency of when clinicians included a topic in amongst their top 7 of clinical topics requiring further research. You can see that there's a sharp cutoff between feeding tolerance and chronic lung disease, topics 9 and 10, and this was the cutoff for topics that were brought forward to round 3. Round 3 was the ranking of research questions of those top 9 clinical topics. And as you can see, the top rated research question was in children with neurological impairment and medical complexity with feeding intolerance, do blenderized formulas versus other formulas improve outcomes? Amongst the top 10 questions that were ranked by clinicians, 2 prioritized clinical topic areas weren't included. That included polypharmacy. The top ranked question in polypharmacy was, what are the demographic and clinical predictors of a medication error? And the other area was behavior. Again, the top ranked question was around demographic and clinical predictors of challenging behavior and emotional dysregulation. And so when we considered these results, we interpreted them in the following way. So we feel that we achieved consensus and that neurologic and neuropsychiatric topics dominated, recognizing that other topics like feeding intolerance or feeding tolerance and aspiration were also prioritized. We really feel that topic generation benefited from parental input. So with behavior, as I cited earlier in example, infrequently proposed by clinicians or not at all in the case of behavior, but both were prioritized by both clinicians and families. We also want to recognize that there's prioritized areas have overlap and that there's definitional vagary. So for example, there's likely overlap between neuroirritability and dysautonomia, and similarly between aspiration, lower respiratory tract infection, and feeding tolerance. Some topic areas were prioritized, but it was difficult to articulate research questions, for example, behavioral and mental health. So we don't have clear outcome metrics or specified interventions, and that may reflect that our participants were mainly drawn from physicians and nurse practitioners. We also again recognize that there's an intentional focus on clinical questions and not the entire healthcare experience. We recognize that service delivery and experience are important, but the focus of this study was on clinical questions. And the strengths of the study is that we focused on panelists that were clinically immersed, and there's diversity both in geography and clinical discipline, and we're very pleased with the engagement rate. So between rounds 2 and round 3, we retained 88 and 84% of participants. And we were also chuffed, I think is the right word, with the input that we received from respondents. So 126 research questions to be generated shows how much there is to be done, and we're very grateful for participants for that. And so, you know, our conclusion is that this was a first step of a research to develop a research agenda for children with medical complexity and neurological impairment, focused on the addressing of everyday clinical questions. And it does reflect the international consensus of both clinicians and caregivers, and that it may ultimately improve the care received by children with medical complexity and neurological impairment. You know, and it has spurred on a second step, which is this seminar series, which we're very grateful is happening now. And Eyal, I hand back to you now, I think.
Thank you, Catherine, for your excellent presentation. What I'd like to do now is pass back to Debbie and Tara for some comments and insights from what they just heard.
I had a story that I shared with our group a couple of weeks ago, and it talked about how our kids with neurological impairment, while they don't necessarily communicate in what people consider a typical way, we as parents learn exactly what they mean and in the context that they mean it. And so there are ways to tell when our son is in pain, when he's uncomfortable, when he's unhappy, when he's just annoyed with something. I actually, because I knew he couldn't actually like form words because he had a nick to his facial nerve. So he lost control of swallow and so forth then, but I taught him how to say because I knew he could vocalize from the back of his throat. And I thought that that would be a really handy way to communicate when he didn't like something. So it's interesting to me, I'll just share this, as we were headed to the ED last week, he knew something was up, and the whole ride in the van, he kept saying, So I just say that as a way to show that it's worth recognizing that our kids communicate like other children. So the story that I shared was one from some years ago, but it really was kind of a pivotal moment for me as far as how I advocate for Josh when he's in the hospital. And my husband was actually on active duty with the Marine Corps. He was in Iraq. And we have 3 boys. So the other boys, I believe they were at home, and I'm pretty sure they were old enough to be there, though I can't remember what I did with them. But anyway, Joshua had been in the PICU, and this was about the time that our hospital was moving the kids with complex needs out of the PICU when they stabilized, and trying just to see how they would do on med surg before discharge. So I'm always the parent who's hesitant to make any changes, and had to be dragged literally down the hall to med surg with our son. But we got him there and things were going well, and he was ready to be discharged. He was stable. I don't even remember what the condition was for his admission. But as a mother who was alone and very stressed about other things, clearly with my husband being in Iraq, a friend of mine from college was coming to stay with me for the night. And so I never leave the hospital when Josh is there. I stay the entire time. I do not go outside. I usually don't even go get meals. I just stay in the room. And before COVID, hoped that people would just bring food. But so Josh was all ready to go home, and my friend had driven from another state to be with me. So the entire staff said, Debbie, Josh is perfectly fine. He's ready to be discharged. We're just going to keep him overnight, and then we think you should just go home and enjoy time with your college friend and pick him up in the morning. And so I didn't want to do it. Something told me not to, because Joshua depends on me, and he always checks to see if I'm still there by his bedside. So he communicates in this way. If he doesn't hear me talking for a period of time, he will say, and he'll kind of raise his inflection to ask a question to see if I'm still there. And so anyway, I took the chance and I left with my friend, and everything was perfect when we left. We're at a teaching hospital at the time. And so I got home and we were enjoying our time together. And then I got a call at about 3 a.m. that they had called a code on Josh. And within 20 minutes, I was out of our suburb into the city, parked, and up the stairs and into his room in 20 minutes. And I stopped, I looked at the room, and all the people who are part of a code were there. The lights were blaring. It was so bright in there. There was a nurse who was bagging Joshua, and he was so small that he was literally just bouncing up and down on the bed with her bagging him. And at the time, and this is part of the picture as well, the nursing staff, they were trying out new oximeters. So they weren't used to the oximeters at all. So Josh was on one of the new oximeters they were testing. And so I stood in the room and I just kind of assessed the situation very quickly. I looked at Josh, who was perfectly pink, and I gathered all the information from all the years prior to that. And then I just shouted, stop. So I screamed stop for her to stop begging him, stop the code, stop everything. I walked over to Joshua and they just did it, I guess, because it was so alarming that I would come in there and shout like that. But I walked over to Joshua and I said, what are you doing? And then he just went, and so he was actually indicating that he was upset because I had left. And so his behavior, because of his neurological issues, prompted something that they considered a clinical emergency. The new oximeters that they had weren't working and people weren't quite reading them well. I don't think they even continued with those oximeters. And Josh was perfectly pink. He was breathing fine. Just kind of assessing the patient, I think, is really important in these instances. And so Josh just breathed a sigh of relief and everyone just kind of lowered their heads and walked away sheepishly. And then I just pulled up my chair and sat there and I said, we are I'm gonna sit here until one of Josh's regular practitioners comes in and discharges us and we're going home. Well, one of the residents at the time had insisted that Josh had pneumonia and that's what prompted his event. But it turns out, as the pulmonologist at the time showed me the films, it was just something that was unique to his film and he was perfectly fine. And so I think that, you know, when you have people with particular disabilities, children with neurological impairment, they're not going to follow any textbook. They're not going to follow any diagnostic tree. They're not going to follow any kind of treatment pathway that is typical for others. So it's so important to recognize that there are people who know and love this person and who have gotten to know the way they communicate. And Josh is an expert communicator in context. He doesn't have to use words, but after just a short time of being around him, people know exactly what he means. And so I just think that the nuances of our kids' communication, the nuances of their medical conditions are so important when treating them. And I don't leave anymore. So.
I can totally relate, Debbie, to the not leaving. Luckily, our children's hospital here in Rhode Island has a food service delivery, so we get food right to the room. And, you know, just a couple of tidbits to share, you know, because we know that every child is unique and every child has their own nuances and own like tricks and tips to, you know, to understanding how they're feeling and what their emotions are. But in the whole, a lot of us parents travel the same journey, right? I mean, overall, if you're looking at the big picture, we're all dealing with, you know, different medical diagnoses. We're all dealing with new information coming in, new things that are being developed, new ways of treatment. And we're also feeling like, you know, we're involved in our life all the time, our nurses and doctors and clinicians and different types of professionals. And sometimes those professionals come with these preconceived notions that, you know, they've been doing this for a long time. They know what they're doing. You know, we've had instances with Andrew with suctioning, where even though they was suctioning to the correct number on the catheter, the way they went about it just wasn't his cup of tea. And so he like would get really upset and start crying. And I've had to say, you know, I understand that you've been doing this a long time, but this is, you know, my son. These are my motherly instincts. I've been treating him myself at home for however long. And sometimes it takes a little while for others to understand that. But we really appreciate when you just give us the time and space to provide you with a little bit of understanding of our child as they're going to be under your treatment, and just letting us, you know, you rely on those motherly instincts and not discouraging parents from having those, because I know many times in the NICU, you know, everything was rushed, like his food, you know, as soon as he got the G tube, all right, as soon as it settles, we'll start feeding him. And oh, he did good with this feed. Next feed, we're going to go up 10 cc's an hour or whatnot, and not giving the child a little bit of time to just adjust to each change as it comes. And so, you know, letting not only the parents, but the child adjust to certain changes and be able to take the time to make sure that the child is comfortable with those changes is really important, because we all know, sometimes things can go well one time and then the next time it doesn't work very well. So we really appreciate you guys letting us, share some of our experiences, and we hope that this will help you understand other families and where they're coming from when you're treating children with medical complexities.
Thank you very much, Debbie and Tara, for the commentary and for sharing your experiences, which I think resonate with a lot of people. I'm looking through the chat box. There are a ton of comments, and I encourage everyone to read through them. I'm not going to go through them myself verbally, because I want to make sure we have some time to address the Q&A, but really important stories and reflections that are so relevant around themes around. I just want to highlight one that Debbie said, I think that really resonated, that Josh is an excellent communicator. We so often hear, as a clinician, you read in the chart, they're non-communicative, they're non-verbal, but that isn't true. Everyone can communicate, they just communicate in different ways. And hugely important to reflect upon the instincts of caregivers and family members in trying to play that almost like that translation role in helping us understand what it is that they're communicating. Because as you said, Debbie and Tara, both of you said, like, you know, once you get to know your children, you actually learn a lot that you don't necessarily see immediately if you meet them for the very first time. So really important themes of relevance to what we're trying to achieve in the seminar series, ensuring that we hear the voice of these children. I want to now call back Rishi and Catherine, and we're going to just have a bit of a panel discussion. There's already some excellent questions in the Q&A, and maybe we can start by going through some of them and then have a bit of an open discussion on some of these issues. So Tara, Debbie, Rishi, I think you're all muted, just to keep that in mind. The first question is, I think probably best directed to Catherine to begin with, because you addressed this, and maybe Rishi, you also mentioned it, but anyone can comment on this. So we presented we presented today about this study which focused on gaps in clinical knowledge. Can you discuss the rationale for excluding healthcare delivery priorities and subsequent need for research? Because obviously you know that's so important to how care is actually delivered.
Thanks, Eyal. I'll try and take a stab at it first, and then I'm sure Rishi will add. I think we know that healthcare delivery is really important, and where one gets care and how one gets it is really important and influence it. However, we were also very cognizant of the fact that there's a real gap in our clinical knowledge, and so we wanted to focus on that rather than taking the broader picture. It's not that these areas aren't important, but we felt that if we were to come with a research agenda that did have a clinical focus, that we needed to focus on the clinical areas, and there hasn't been a huge amount of clinical research focused on this population. So that was what motivated us to think about the clinical topics and why we excluded healthcare delivery and various other areas. It was just a little bit beyond the scope of what we were trying to achieve.
Yes, I would agree with everything that Catherine said. I think that healthcare delivery and systems issues are critically important and have such a strong bearing on outcomes. But we felt that there was just a gap in discussions about clinical topics, and so we wanted to focus on that for the purposes of this project.
And a follow-up question, I'm interested in particular in Debbie and Tara's perspectives on this. So there wasn't a ton of family members in that prioritization project, right, Catherine? It was mainly around the initial list, and it was just the social media accounts, if I remember correctly, of investigators. It ended up that most of the families who were recruited were, I think all of them were from just 2 countries. So a question about whether we may be missing some question topics that families might reflect on from other countries, in particular the US. And just a reminder, the topics that were prioritized were irritability and pain, mental health, disorders of tone, polypharmacy, sleep, aspiration, behavior, dysautonomia, and feeding intolerance. So any thoughts about, and maybe this is a good way of kind of a segue to the question, is there anything that's missing in that list or things that are there that are surprising when you look at that list? Maybe I'll start with Debbie and Tara from the perspective of caregivers.
I know
Um,
when we had our initial call with the other families that were going to speak on this, it was brought up that genetics was missing, and that was typically a big topic. And I know that, you know, in the US, we have regional genetics networks, and I know they do a lot of work around providing information and education to providers and families. So I didn't know if that was maybe a reason why. And then one of the other things which I did see brought up in the Q&A was palliative care, and you know, how to promote palliative care, that it's not just end of life care, it's quality of care. That was one thing that I did notice was missing. I'm not sure if Debbie had any additional thoughts.
Thanks, Tara. You know, one of the things that came to my mind, especially this week, is how we need to rethink how we approach that transitional period from pediatric to adult medicine for children and youth with neurological impairment, because they're, I don't know, I guess the way that they act clinically, I'm finding, like for my son, even though he's in his 20s, is more as a pediatric patient rather than an adult patient. And I think there's just this whole area where the neurological impairment kind of clouds some of the straightforwardness that we often find in a diagnostic approach in adult medicine. And so with Joshua, for example, when he is ill or something acute is happening, it goes really fast, kind of more like you'd approach a child. And there are other things that kind of skew the picture that are probably baseline for him, that are part of his neurological situation, that would actually be like tested and diagnosed to death, but they're actually just part of his baseline. So I think there's just this little place for more research on transitioning these kids, because they don't transition the same way as typically healthy children, or even children with special needs who don't have neurological impairment. So, and it can be life-threatening if we don't kind of consider that approach as well. And so that's kind of what I discovered recently.
I wanted to make one other point, is that while the study focused on prioritization and identified a list of you know, the topics that were rated highly, that doesn't mean that the other topics are not important. And I think that's really important. You know, ultimately what makes the top 10 will be driven in many cases by the sample of the people who you ask, and different people will have different perspectives on that, and that's perfectly fine. But we've published in the supplemental online content a list of all the topics that were identified in tables S1 and S2 by both the families and the clinicians. And I hope that many of you will use that as a guide for looking at potential areas that at least some folks had thought required more investigation.
I'd like to move on to the next question, because there's a lot of great Q&A coming in through the chat, through the Q&A box. So this is a bit of another, just one more question I think I want to, around the conceptual framework for the prioritization product. So a question is, that came up from Galen. I noticed that many of these topics relate to palliative symptom management, but it actually isn't delineated as an actual, like, goals of care or advanced care planning as actually one of the prioritization topics. So maybe a question, I'll start with Rishi on this one, because I know we've chatted over the years about what is complex care, and where does the overlap with other existing fields, and your thoughts on where, you know, palliative care type topics fit into this prioritization framework.
Absolutely. I think those are very important. Thank you so much for suggesting those. I think that we narrowed our focus a bit, again, because we saw a big gap in this area, to the questions, clinical management questions, as opposed to clinical process types of, or clinical systems types of questions. But there's a whole area of pursuit, about how do we look at goals of care or various other quality improvement initiatives that are, neither pure clinical questions nor, health services systems research per se. So I think, really an all of the above strategy is very important for this, and certainly, but the way that we asked the questions and the way that we framed the study was focused on specific clinical management, but not to exclude the importance of all that you raised.
Any comments from any of the other panelists?
I just wanted to mention that regardless of the topics, or not regardless of, but looking at the topics that were listed, I think it's just so innovative that we're even having this discussion and that you did this research, because, having been kind of around for a long time, kind of since the beginning where our kids were able to survive the NICU and come and kind of thrive in their own way, whatever that means. We haven't seen something like this. And so I just think it's so important that we are addressing this. So thanks.
So I'm going to move on to a question about what do we do with this information that was gleaned from this prioritization project. So a question from Rhonda. Do you have suggestions how to best answer the questions? Clinical trials, medical chart review. And this was a similar comment that was made by a colleague of ours, Matthew Sandoff, who said in an offline topic comment, can we start to develop registries across practices to start to figure out ways to better improve clinical care for these kids?
Is it okay if I go first? I think this was the next step, actually having a conversation with everybody who's involved in the care, families too. And I think the logical next step is I think we need to think about some definitions for this particular population and some standardized terminology. For example, if we take neuroirritability or irritability or pain as it's known, and I care for patients who have all of those things, and Dr. Howard, Judy Howard, is speaking about it at next month's seminar. I think we use language in clinical practice and with families, but we all use it slightly differently. And I think if we're to advance a research agenda, then we actually need, with the limitations that are there of definitions, but I think we need to have some definitions so that we can proceed with trials or with whatever else comes next. But I think that's a first step. And I think a step that goes with that is involving families, but also asking families, what are the important outcomes? Because I think as important as it is to have definitions, it's really important to have relevant outcomes for families and for children and for clinicians. And I think those two steps would then inform future research, and I think they're necessary.
Great, I'm happy to add to that. Yeah, I agree with everything that Catherine said. I mean, I think this is a complex problem. How do we start to tackle all that we've identified? And the short answer is we need more clinical research, but the question is, how do you get there, right? I think that we have to think about our workforce for who can do clinical research, and think intentionally about how do we build that up. And it may be people within the complex care and special needs world, but it also may be us reaching out to our colleagues who are subspecialists, whose work often overlaps with ours on many of these problems, and trying to create, just as we create multidisciplinary teams to address clinical care, maybe we need multidisciplinary research teams as well, and to think about how do we create them. We certainly, clinical trials are the gold standard of how we determine how we do science, but sometimes you can't get there right away, and so I think there's an important role for observational studies as well that we can do using existing data or the data that we collect. we probably have to work together more, because any single center may not be able to do this themselves for many problems. If you have a small number of patients who may have a particular issue, we have to sort of, I think we have to think more about how do we collaborate across centers doing multi-center research. Whether that involves a research network or not, that remains to be seen. But I think that we have to, and Dr. Sadoff suggested offline registries. That's an important potential building block as well. So I actually will ask our esteemed MC to actually weigh on this as well. You're facilitating the discussion, Eyal, but I'm sure you have some thoughts on this as well. Would you like to share?
Yeah, I mean, one of our not so secret ulterior motives for developing the seminar series is to try to develop a bit of a community of practice of people who are interested in developing ways of improving clinical care by improving knowledge for the children that we care for, either as family members or as professionals. I think it doesn't have to, it could be, there are many ways it can happen, and it's one of those, you have to take a multi-pronged approach. It can be big, large trials, it can be big, large registries. Those things, there are mechanisms to move those forward, but they take a lot of work and coordination to do. But little things can work as well. If you're in a single center, if you have a small network or practices that can get together. And I think it was Atul Gawande who wrote this. You don't know until you count, right? Like, you know, we do a lot of things off-label without clinical practice guidelines. Like, if we just in a systematic way start measuring what the outcomes are about things that we recommend to families, and that I think that would go a huge way in saying that in starting to develop a bit of an evidence base. So, you know, I think it's a multi-pronged approach. That would be what I think needs to happen. I think over the course of the seminar, hopefully we can start developing some organically created groups that are interested in tackling specific questions that are addressed over the course of the seminar and figuring out different ways of doing that. But certainly the beginning of it is networking and finding people who have collective interests and the will to and curiosity to try to figure out ways of doing things better. I didn't know I'd be put on the spot, Rishi. I think we only have a few minutes left, so unfortunately we're not going to get to all the questions. Maybe I'll just end by thanking everybody for joining today and just giving a few kind of comments about things that are going to be coming up with the seminar series. So huge thanks to our panelists, Debbie, Tara, Catherine, Rishi. There's a ton of comments in the chat box, and I encourage everyone to read them. And I'm sorry we couldn't get to all the questions. What we're going to do is you're going to get a link to a website at the when you fill your evaluations that's being hosted by Packard, and we're going to have a lot of the resources that were discussed today also put on that webpage if people want more information. So hopefully that's an incentive for people to complete your surveys, not just to claim your CME, but also to help link you to the other information we have available from this series. I want to give a plug also for our next seminar series. So I think it's been alluded to briefly that our next seminar is on Thursday, October 14th from 1 to 2 p.m. And it's on a very important topic that was definitely prioritized by many people in the work that Catherine presented today. And it's on irritability and pain. The guest speaker is Dr. Julie Hauer, who actually authored clinical practice guidelines for the AAP on this topic and is a fantastic speaker. She's going to be joined by Caitlin Scanlon, who's going to give a social work perspective on this really important topic, as well as family speakers and experts, Sarah Tuller and Shonda Hicks. And you're going to receive registration link in your email, and registration is going to be open. So on that note, I just want to thank everybody again for joining today, and really appreciate everyone taking the time. And we look forward to seeing you in October.